I'm not going to be talking about something that's life-threatening. I remember someone telling me that, endocrinology is a lot of things that we deal with, like thyroid hormone, is just not that big a deal. We're dealing with cardiac patients and ICU patients who could die. Endocrinology is just kind of icing on the cake. And I would say that there are things that you can die from endocrinology, as we just heard about last hour, but you're not going to die from delayed puberty or infertility. But it is kind of the icing on the cake. And the person's reply to the criticism was that, well, the icing's the best part. And so, even though this is not life-threatening, it's a very important aspect of our lives and really becomes a major focus. So this is my disclosure. I'm going to talk a bit about just normal puberty and how that normally unfolds in boys and some of the hormonal events as well as the physical changes that occur as a reference point. And then talk about what's known, or really what little is known about puberty in boys with APS1 and about fertility later on in life. I'm just going to skip to the end in case people drift off. The take-home points are that in boys and in girls, there's a fairly wide range at which puberty can occur. In boys, it typically starts anywhere between 9 and 13 and a half or so. So if there haven't been any puberty changes by 13 and a half, 14 in that range, that's when you start to get concerned. There's really not a lot of published data on pubertal timing in boys with APS1, and I'll talk about that. Most men with APS1 have normal functioning of the reproductive system, but there are some men who have problems with producing testosterone, and they may need treatment. And then, for reasons that aren't entirely clear, fertility is often reduced in men with APS1, and I'll go over some studies that suggest that there are some treatments that may help some individuals. So I'm going to talk first about normal puberty. So in the reproductive endocrine system, we talk about the hypothalamic pituitary gonadal axis. So what that means is that it starts with signals from the brain, a particular region of the brain called the hypothalamus, and it sends signals to the pituitary gland, which then responds by producing hormones called LH and FSH. We'll call these the gonadotropins. They circulate in the blood, and they're actually what we often measure in our blood tests. And then those trigger the testicles in boys to produce other hormones. Testosterone is the main hormone, as well as some other hormones you can measure, and also eventually to produce sperm. And it's really testosterone that's the key hormone in boys that triggers most of the changes of puberty that I'll talk about next. So here I'm going to go through all the various changes and kind of give a rough timeline for each of these. It's very rough because there's a lot of variability from person to person. But there's some things that we know appear at the beginning of puberty and then progress through puberty over many, many years. I often tell people that you look at high school seniors and compare them to high school freshmen, they look very different. But you even look at college seniors and compare them to college freshmen, and they look different too. They're not necessarily getting taller, but they're ongoing changes that testosterone and other hormones bring about for many, many years. So the first sign of puberty that we notice as pediatric endocrinologists is an increase in the size of the testicles. Now, normally people aren't paying attention to this, but in the clinic we do, and we can see that there's kind of this magic number of 4 ml size of the testes. When you hit that number, we know that the body's entering puberty. And then there's gradual growth of the size of the testes, and they increase in size about 10-fold from the very beginning to the very end of puberty. Hair growth is another sign that appears early, and hair appears in a lot of different places. Usually the first place you start to notice it is in the pubic region, and then on the arms and legs, the forearms and the lower legs, and then underarm hair, upper lip, chin, eventually the cheeks. I put chest hair as a fairly late appearance, and I put it in parentheses because not all men develop significant chest hair. I think what we think about a lot in puberty is the growth spurt, and this is a little graph showing the rate of growth, and you can see that at the start of puberty, before puberty, kids are growing at a rate of roughly about 2 inches a year. But then by about mid-puberty, there's that growth spurt that happens, and boys may grow up to a rate of about 4 or even 5 inches a year at the very peak growth rate. And then eventually the growth plates mature enough that they fuse and they stop growing altogether, and the growth rate drops to 0, and that's why we don't keep growing taller for the rest of our lives. The voice change occurs about mid-puberty, about a year into things, right around when that growth spurt is starting to hit its peak. And sperm production starts roughly around the same time and then continues through the rest of life. The increase in muscularity that we associate with puberty tends to be a relatively late occurrence. And the way I describe it to people is that, first you kind of grow tall and then you fill out. And that's the pattern we typically see. And again, these all occur at fairly in a characteristic sequence, but it does vary a lot from person to person. And so there are some boys who have chest hair in the 8th grade, and there are others who will never have chest hair. And so there's a lot of individual variation. Speaking to that variation, this is a graph showing when puberty starts in boys. This is actually a study that was done in Copenhagen, in Denmark, and they actually looked at 2 different times. I think the overall message here is that this is, again, when puberty first started, when we first see that sign of the testicles starting to enlarge. There's a wide range of ages at which this occurs, so that most boys, nothing's happening yet by age 9. By age 13 and a half and 14, most boys have entered puberty, but again, there's a lot of variation. The average is probably around 11 and 11 and a half, plus or minus a good 2 years on either side. The other thing about this is that they actually did this study twice. They did it in the early 90s and in the mid-2000s, and the 2 graphs show the difference. You may have heard a lot about, in girls in particular, studies that have demonstrated that puberty, or at least breast development, seems to be occurring earlier. And so people ask the same question about boys, and this shows that overall across this 15-year time span, maybe things are occurring a little bit earlier, but on the order of maybe a few months, so not significantly. So that trend towards earlier puberty in girls doesn't seem to be as pronounced in boys, so there may be a little bit of something there. So again, as clinicians, and as we think about when do we start getting concerned if puberty is occurring too early or it hasn't occurred yet. And again, the general guidelines are most boys start puberty between 9 and 13 and a half. And so if you see signs of puberty before 9, that might be reason to be evaluated for precocious puberty. And if nothing's happened yet by age 13 and a half or 14, we would consider that delayed, and that would warrant investigation. So what happens in boys with APS1? Well, first thinking kind of theoretically, how could APS1 affect the male reproductive system? I think one possibility, and this is more theoretical, is that there's a lot of similarity between the adrenal hormones, cortisol, that is essential for stress, as you heard from Dr. Aukus. And there's a lot of similarities between adrenal hormones and testosterone. They all fall in the class of hormones called steroid hormones. They're so named because they're all derived from cholesterol, and that's the basis for the name. It's a little confusing because you'll hear people talk about steroids, and you don't always know if they're talking about glucocorticoids like hydrocortisone and prednisone, or if they're talking about anabolic steroids like testosterone that people like bulk up in the gym. Sometimes you have to ask, like, do you mean steroid, meaning like testosterone, or do you mean like hydrocortisone? Because they're all derived from the same cholesterol, a lot of the enzymes that are involved in converting cholesterol to these hormones are shared between cortisol and testosterone, and they exist both in the adrenal glands and in the testicles to be able to produce these their respective hormones. As you know, and as we've seen many times, about 2/3 at least of patients with APS1 have autoimmune adrenal insufficiency, and a lot of times they have antibodies against some of these enzymes in the adrenal gland. And so theoretically, the immune system could also affect the testicles, causing a problem in the testicles themselves, what we call a primary testicular problem. APS could also affect puberty indirectly, and that's because the entire system, starting from the very top, so these neurons that I mentioned in the hypothalamus that make a hormone called GnRH, on down through the pituitary gland and the testicles, the whole system can get shut down by chronic illness, high doses of glucocorticoids, such as, again, hydrocortisone, prednisone, that are sometimes used for immunosuppression. And so for both of these reasons, you can see suppression of the entire reproductive system, even if there's not an actual problem with the testicles themselves. It's just a normal response of the system to either stress or some of these medications. So what actually is known about how APS1 affects puberty? I'm going to talk more generally about male reproductive function, and these are mostly studies in men, not in boys. I'm going to go through a series of 4 studies I found that actually address this topic. The first is a cohort of 45 individuals from Finland, and what they found is that by age 40, about 12% of them had a problem in the testicles themselves, a primary testicular problem, and one more of them, at 4% more, had that problem where it looked like the whole system was shut down, that they could tell that the pituitary gland wasn't making enough FSH and LH, so the testicles weren't making testosterone. Another study of 28 men from Italy found no abnormal problems with the male reproductive system. Another study from Norway showed that none of 28 men had a problem with the testicle itself, but one of them had that issue where the whole system was shut down and you had decreased production of FSH and LH from the pituitary. And then the fourth study was 12 men from India. Again, none of them had any problems with the testicular function itself, but one of them had that decreased activity of the whole system. Now, contrast this with the high rates of ovarian problems in women with APS1 around on the range of, I'm sorry, that should say 2/3 of Norwegian women, not 1/3. So on the order of 2/3 of women have issues with the reproductive system, and Dr. Gordon will talk about that more in a moment. But there's a marked difference between how the male system is affected and the female system. There's a good reason for this. The testicles are considered one of the parts of the body that have that are quote unquote immunologically privileged. It so happens that you have these cells in the body in the testicles that actually create a physical barrier between the bloodstream and the inside of the testes, and this so-called blood-testis barrier prevents immune cells from entering the testis and can also prevent antibodies from crossing over into the testis, and so the testes may be protected from some of these immunological effects. But it's not a perfect system. It's not a complete barrier, and as we can see, some of those issues with men with primary testicular problems were probably due to the immune issue. Now, with regards to the actual timing of puberty in boys with APS1, I actually had an earlier version of the slide that said that we actually don't know much about this, but Dr. Weiner weighed in and said, actually, I've seen a lot of patients with boys with APS1 who did have delayed puberty. But the issue is that there's nothing in the literature about this. And I think this is a great opportunity to use things like the registry to do a research study to ask about this and really get this information out there because it's not in the literature right now and is not widely known. So if delayed puberty does occur, fortunately there are things we can do about it. And what we primarily use is testosterone replacement. So the main hormone to induce all these physical changes is testosterone. And one of our basic principles in endocrinology is that if the hormone is missing, you replace it. And so we can replace testosterone like we replace many other hormones. The general concept is that we start with a fairly low dose and gradually increase this dose over 2 or 3 years to copy what the body would normally do in terms of testosterone production, starting with very little and then it builds up to adult levels over about 2-3 years. Occasionally, this would be if you're trying to bring someone all the way through puberty using testosterone, assuming that they are not going to make any testosterone at all on their own. But oftentimes, boys with delayed puberty, they're just late to start. And this is really more kind of a way to bridge until their body starts producing testosterone on its own. Or there's some thought out there that testosterone may actually encourage the body to start puberty on its own and may kind of jumpstart things, though that's kind of more theory than proof and based on anecdote. But the reality is that if the body starts to enter puberty while you're treating, then you can stop the treatment and let the body take it from there. So a lot of times treatment is really only needed for about 3 to 6 months, maybe a year, and then you can stop treatment and again, the body's own puberty can finish the process. Testosterone is usually given as an injection. There's no oral preparation of testosterone that we can use right now in boys. And it's usually given as injections about every 4 weeks to start, and then you can do it more and more frequently up to about every 1 or 2 weeks. There's also a gel formulation that you put on the skin and you let it dry off. I tend to avoid this in boys with pubertal induction for 2 reasons. One is that it's hard to give doses small enough that you want using the gel. It just doesn't come in that small a dose. And the other thing is that I don't really trust the boys to use it properly. If it gets absorbed through their skin, if they don't use it properly and let it dry off completely and wash their hands, then they could expose other people to it as well in the house. And there are plenty of cases reported of household contacts being inadvertently exposed to the testosterone, so I just try to avoid it. So the good thing is that this can induce all of the changes of puberty except for the increase in testicle size, which requires some of the signals from the pituitary gland and will not induce sperm production. That requires specialized treatments if there's a permanent problem. Again, if puberty kicks in on its own, then fertility should be achieved normally. One thing I remind boys who are delayed is that these changes changes will appear, but they're going to appear at the same pace that they would normally. And the boys, sometimes they come in at 15. I look like I'm 12. I look way younger than my peers, and I wanted testosterone yesterday, and I want to look like them tomorrow. And I have to remind them, again, these changes take time. They take several years. You're going to start going, but you're not going to instantly wake up and look like all your classmates who've basically made it through the entire process. So you will catch up eventually, especially when they slow down, but you have to be patient with it. And I have a lot of boys come back after 6 months and say, it's not working, nothing's happening. It's like, no, it is working. It's just going to take some time. And then moving on to fertility, the only data that I could find is from that one cohort study from Finland with 45 men, and by age 40, a good roughly quarter to a third of them had decreased fertility. Now, some of them were because they had those problems with testosterone production, either because the testes weren't working properly or because the whole system was shut down. But another 3 individuals in that cohort had completely normal hormone production, but had decreased sperm production. Why is that? We don't entirely know, but there's some theories out there. There's some data from mice. This is a study that looked in mice with a mutation in the AIR gene. And what they found is that these male mice had reduced fertility. But if they engineered these mice to be immunodeficient on top of having the AIR mutation, those mice had normal fertility, suggesting that it was the immune system that was causing the infertility. And they also did a neat experiment where they took the immune cells from these AIR mice and put them into AIR non-mutant mice, regular mice, and then that also caused reduced fertility in those mice that received those immune cells, really suggesting that it is the autoimmunity that's causing the reduced fertility in these men with APS1. So what's the target of the autoimmunity? It's not entirely clear. For a long time, people have looked at anti-sperm antibodies that they can find in some of the men with reduced fertility. There was an experiment that was done recently where they tried to find male-specific antibodies. So they took blood from men with APS1 and women with APS1, looked at the antibodies and said, what's different between these antibodies? And what they found was antibodies to a protein called transglutaminase 4 in about half of the men with APS1. This is a protein that's present in the prostate gland. I hadn't heard of it before. I think most people hadn't heard of it before, but it came out in this study. What's interesting is that they found that these antibodies only appear after puberty with maturation of the prostate gland, and they suggest that this could be a possible mechanism for how infertility could occur. The function of the prostate gland is to produce some of the secretions that are really essential for normal sperm action and motility, and so they hypothesized that maybe this could interfere with prostate function and thereby cause the infertility, but not entirely clear. So a couple of words about treatment. There is not a lot about treatment of the male infertility. There is one case report of a single 26-year-old man. This is a case report that's over 20 years old now. He had no evidence of any hormonal problems, so he had normal testosterone, but he did have a low sperm count, and the sperm that were there weren't moving at all, had no motility. And this is an individual who had those anti-sperm antibodies that I mentioned before. They treated this individual with a course of steroids, prednisolone, and what they found is not only did it decrease the amount of those anti-sperm antibodies, it increased his sperm count, improved the motility, and eventually led to a successful pregnancy in his partner, not him. So in another study, 43 men with reduced fertility and anti-sperm antibodies. Now, this was a study of just infertility. This is not necessarily men with APS1, but they also treated with a course of prednisolone, and they found that this led to a successful pregnancy in their partner in about a third of the individuals treated. They had actually it was a kind of a complicated study. First, they studied them on the prednisolone and then off the prednisolone, and off the prednisolone, the success rate was only 10%. So there did seem to be an improvement with prednisolone, but it still was not 100%, so not a sure thing. So again, that's what I was able to find, and what I've shared with you. So just to reiterate those take-home points, that there's a broad range of ages at which puberty starts, but if it hasn't started by 13 and a half and 14 years, you should be concerned about delayed puberty and probably consult with a pediatric endocrinologist. There's really not much data on pubertal timing in boys with APS1, but some experience that suggests that it may be late frequently. Testosterone production is often normal, but not in men, but not in all men with APS1. And if there's a deficiency in testosterone, either in the adolescent or the adult years, testosterone treatment is available. And fertility is often reduced in APS1 for reasons that aren't clear, and it looks like steroid treatments may help, and whether other treatments might help as well is unknown. And I think that's another ripe area for future studies.